Good evening, friends and colleagues. Welcome to ESGE webinars. This is another new series of webinars. It's the live endoscopy webinars, or today I should say video live endoscopy webinars. And I'm pleased and honored that together with my friend George Webster from UCL in London, we will start this new series today. We have started a bit earlier today because we planned for 90 minutes, and the idea is to select different centers in Europe transmitting. Initially it was planned live, but because of Corona we will start with pre-recorded videos and showing you detailed procedures, techniques, and so on the developments. And today we would like to start with a topic on duodenal adenoma, and you have the chance to ask questions, answers. Please use the chat function, and I would like to share my screen and welcome George. Thank you for supporting this idea. I know as a president sometimes you have a lot of ideas, but in this situation, I think it's quite helpful to have an experienced endoscopist who's doing live endoscopy also from his unit with live London Live, and therefore it's a great pleasure to have you also here and that we together can start with this project.
Great. No, Helmut, I think this is a great and exciting innovation, and I see we've got several hundred people attending already. And I think there's a reason for that. We've chosen a topic that on the face of it, for the opening topic, is a little bit unusual, but it's not that unusual because all of us in our practices doing diagnostic gastroscopy, we come across duodenal lesions not that uncommonly. And I think duodenal adenomas, both ampullary and non-ampullary, are lesions that most of us feel a bit uncertain about. We see them, we're not quite sure how to assess them. We're certainly not very sure, how we should be removing them and whether we should be doing it or whether we should be referring on to other specialist centers. We have an inherent worry about these lesions. A similarly sized colonic adenoma we would remove without much anxiety, but it's a little bit of a different story with duodenal lesions. And so I think all of us are really excited over the next 90 minutes to see some cases, both seeing how to do it perfectly and also recognizing that things don't necessarily go perfectly all the time. And I think it's going to be fantastic to have Marc Barthet from Marseille and Marianna Arvanitakis from Brussels with us to add their expertise to the discussion. So I think we're pretty much ready to get stuck into the endoscopy room and start seeing some cases and start having that discussion about how we should be dealing with these lesions. And as you said, Helmut, we really want people to fire in their questions. We will either address those questions in the live discussion, or we'll do our very best to respond to them during the course of the webinar. So I think we're pretty much ready to get going, and I'm very
and as you said, we have Marc Barthet as an expert also invited, and Marianna will explain the guidelines of ESGE. So the idea is always to have the guidelines at the background. Is this correct what we do? And I'm also happy to have my co-workers Alanna Ebigbo and Andreas Probst, who do a lot of ESD and EMR in the duodenum. So we start with the first case, and yeah, these are my disclosures. And now I would like to start with a case of a 86-year-old male without any comorbidities, and he had just EGD because of nausea and vomiting. And this was the initial lesion we saw. So 86-year-old, huge lesion, obviously including the papilla, was not really visible. Where's the opening and the orifice? And now this is with a duodenoscope, and now again using always both type of scopes. Use a duodenoscope, use a gastroscope with a cap for precise diagnosis, for differentiation. Is it a malignant or is it a benign lesion? The majority of these lesions are benign, and you see this huge lesion. And I'm wondering how to proceed. And please use now the function for answering questions to vote. So we were asked at the referral center, should we perform an EMR, or is this a case for surgery, or because of age, can we wait and watch? And I would like to ask our participants, what would you do in your hospital? What would you recommend to the patient? Would you go for endoscopic resection? In this case, piecemeal EMR. Would you recommend surgery or wait and watch? And now you can vote. And so there are 57% going for EMR, 26% for surgery, and wait and watch 16%. So what we did is showing here. Indeed, we started with EMR. You will see the proximal part of the lesion almost started the resection, and then we continued here with a special needle. Sometimes it's better to have a needle with a steel sheet, and it worked quite well. Yeah, the resection. You see a nice lifting. There is no risk for malignancy, and we could inject. Very nice. And then there was a small hole visible. Yeah, and I was a bit afraid. There were air bubbles coming out. Was this now a small perforation? And it started bleeding. Yeah, you see it's bleeding, and it's suspicious for a very small perforation. And now my question to you, what do you would do right now? Would you clip? Would you stop and send the patient to surgery? Or wait and watch, which means stops the procedure, needle by mouth, antibiotics, and yeah, decide the next day what to do. What is your suggestion? What is your recommendation? Clipping and continuing, stop and surgery, or do nothing and just a conservative treatment? So the majority, 90%, would clip, surgery, and 7% wait and watch, 3%. Right? Yeah, indeed, we started to close the defect with clips, which is quite difficult, as you can see, using a duodenoscope. And then the bleeding was more severe, and I had to use now a gastroscope with a cap. I used a cork grasper and stopped first this bleeding, knowing that there might be a very tiny small perforation. Yeah. And then I decided for a Ovesco clip, because with a over the scope clip it was not possible. And maybe you can see this very small perforation. It was here, and then was here is the perforation, very small, 2 millimeters maybe, and then yeah, the clip was placed, and yeah, this is the result at this stage. Here you see the Ovesco clip, and this is still something in place. Now again, can we continue again surgery, or stop? Should we stop now the procedure because we closed the defect, we stopped the bleeding, and we can wait for a day? What would you do in this situation? Yeah, EMR continuing 60%, 1/3 would stop, and a left minority of 10% would go for surgery. Yeah, I continued to resect because the patient was stable. I think this is always important to know, how is the patient situation? Can you continue, or is there any problems? Patient becomes unstable, which was definitely not the case. We do this procedure in sedation, and now you see we continued with the snare. We form the resection, and this is now the papilla opening. You see the orifice, you see the nice papilla, and we can continue piecemeal EMR very safely. But always keep in mind, how is the patient's situation? Is it still in a situation where you can continue or not? And yeah, after a couple of resections, I think I can continue. This is a papilla. We did a papillotomy because to see whether there is there was some intraductal adenoma, but then you see looks pretty good, and we could continue. And at the end, there's always the question, here is some adenoma coming out of the papilla, yeah, of the orifice, but then we stopped. And the question is always, when you stop, or you have resected everything and you see this bile coming out, is there a pancreatic stent necessary? In principle, yes, we would recommend. And then you see here the pancreatic stent, and we put some Purestat to avoid delayed bleeding. Yeah, the data to this will be discussed later, but this was my first case, just as a starter. And now here is a procedure from our live, and this is pre-recorded because of Corona, and we'll start it.
The adenoma is papilla. There's some bile, yes, but I can't detect at the moment the orifice. So let's first start a little bit with cleaning. This is position a bit. Yeah. All the patients will receive some diclofenac for post-pancreatic all. It's just, yeah, I mean, I will remove it anyway. Yeah. And I'm wondering, yeah, this is here. The question always with adenoma at the papilla is injection necessary or not? And there are data and even randomized trials showing that there is no clear benefit for the injection. So I will use now a okay, you got it. Now the color of the adenoma changes a little bit, and I think we are in a good position and can start with resection. That's it. So we're kind of bleeding a bit out. We remove the piece off here. Take it back in the stomach. We have no severe bleeding, so we can remove it very quickly. And we need now to clean and wash. Otherwise, we won't find the opening. So cork grasper. Here is the bleeding spot. I think very good visible. And now we change to the cork grasper. Close. Oh, okay. I think we got it. Raus. So now we will clean again. Yeah, which we can resect with a small, smaller snare. So my next step would be to resect here and then place a stent in the pancreatic duct. Very stiff, open. Yeah. Yeah. Yes, we got it. So just a small piece. I think okay. So this is the bile, yeah. Yeah. Okay. So no intraductal adenoma. Yeah. Yes. Okay, stop. So now we place a guide wire. We use VisiGuide from Olympus and the pancreatic duct, and then I tried to close the resection area with some clips.
Sorry, no. This was the very end, pancreatic stent, and then the closure of this area.
Let's change the scope, perhaps using a gastroscope with a
just now with the gastroscope and the cap, and we closed it. Yeah. So the question always is injection or not injection. Just for your information, a randomized trial with 50 patients, and then you see in one group injection, one not injected. Is there a benefit for injection? I don't think so. Or the guideline doesn't recommend. The complete resection was in favor of not the injection group. So I think we definitely do not need injection for a regular ampullary adenoma. Next case is a non-ampullary lesion.
Here we are EMI safe and treatment of choice in Europe so far. It's not a good candidate for a block resection, and although FTR resection, this lesion is too big. So this is now the white light image. You have also in the near focus image, so kind of two focus system, which is much brighter than the previous system. It can really have nice image of the mucosal pattern and the vascular structure. Again, this central part seems to be crucial, whether here is cancer or not. Now we have using the zoom, have the impression that this is an invasive cancer. And also by using underwater, you see the polyp is floating. This is also for me a sign there's no invasiveness. Here could be, so I switch now to another mode. Now this is a TXI mode. So indeed this is in the center, but we now switch again back to NBI. The density of the vessels on the lower part is much higher, and then the upper part a little bit less vessels. Mucosal pattern regular in this quadruperant area, also regular here. So watching the center. Perhaps for injection we use glycerol. Yeah, and I knew for resection I use now a 50 millimeter monofile snare. Close. Yeah. Okay. Here we are starting the upper part of the adenoma. I prefer to take a cork grasp in this situation, and we can now switch to RDI, red dichromatic imaging, and this is amber color. This situation sometimes muscle muscular propria slips out of the yeah. Tack. Ja, langsam zu. Ja, zu.
Sorry. So going to the end.
It was had a shape like a V. So there is in between a small area where we resected. I start here with the clip open. Close. Close.
Yeah. Okay.
Yeah. Okay.
Yeah, this was 3 cases, and now I think Dr. Probst can present the data from our series where we performed this resection technique. So, Dr. Probst, maybe you can comment the paper where you were the first author, the EMR of ampullary and non-ampullary adenoma.
Yes, of course. Good evening together. We are always afraid of bleeding and perforation when we resect in the duodenum, and therefore we performed a prospective study to evaluate the real life regarding this topic, and we included 118 adenomas. There were 87 non-ampullary adenomas and 29 ampullary adenomas. And the size of the lesions was big. 1/3 was larger than 3 centimeters, and only a minority was smaller than 1 centimeter. And we examined these procedures. Can you go to the next slide, please? And what you already have seen in the videos, we always perform preventive measures to avoid delayed bleeding, and you could see clipping, you could see coagulation forceps and in our patients. We performed clipping in more than 60% of the lesions. We performed coagulation in 24%. We used topical agents like Hemospray, Purastat in 15% of the patients, and only less than 20 patients did not receive anything, and this was the majority of these lesions were small lesions, less than 1 centimeter, and the big lesions are all received preventive measures. And what did we achieve with this strategy? Despite this extensive use of clips and coagulation and topical agents, we had delayed bleeding in nearly 20%, and 14% were major bleedings. And when we look at the different lesions, we can see the delayed bleedings mostly occur in non-ampullary adenomas when they are larger than 3 centimeters. It's 40% in this study, and in non-ampullary adenomas and in ampullary adenomas. And when you look at the ampullary adenomas, the size doesn't matter so much. In small lesions, we have 32% of delayed bleedings. And when they are large, we have 40%. So these results show the high risk of delayed bleedings, and we cannot be satisfied what we reach with our preventive measures today. And so we have to improve this. And there are new data from Japan. Next slide, please. This is another slide which shows the difference between non-ampullary and ampullary adenomas. And you can see when you take all non-ampullary lesions together, the risk for delayed bleeding is 13% compared to 34% for ampullary lesions. And also the risk for perforation is higher in ampullary lesions. It was 6.9% compared to 3.4% for non-ampullary lesions. And so we have to improve our preventive strategies. Next slide, please. And there are data from Japan for closure of the resection ulcer. And the data from Japan mostly include patients with endoscopic submucosal dissection, ESD. We usually perform EMR in Europe and ESD only for selected patients in expert centers, so it's not comparable. But the the colleagues from Japan showed if they completed the closure of the resection ulcer after ESD, the delayed adverse events rate was only 1.7%. So this is much lower compared to our rates of delayed complications. And there is another strategy. Next slide, please. Closure of the resection ulcer using OTS clips. And also this data are after ESD. And also this data show a very low rate of delayed complications. So maybe this could be an option, but as I mentioned, the data are only after ESD, and nobody knows if it's comparable to EMR, because we all know if you perform EMR, you have a risk of residual tissue and recurrence, and nobody knows if this may be a problem when we close these resection ulcers. Maybe not, because we know the data from colorectal EMR and closure of the defects, but nobody knows if this is comparable to the duodenum.
Okay. Thank you, Dr. Probst, for presenting our data and the way how to prevent bleeding. Another topic to prevent bleeding may be topical agents. Dr. Ebigbo, I think you can present this next slides. This is a case which were performed by you, and there is a small video. Maybe you can comment on this.
Yes, thank you. Good evening, ladies and gentlemen. One possible strategy to approach the issue of post-polypectomy bleeding or delayed bleeding could be not just a multimodal approach using clips, coagraspa, but also adding a topical agent such as Hemospray or Next powder. In this case, I'll show you a classical piecemeal EMR, which I performed in the duodenum using injection solution here, normal saline with a little bit of adrenaline, and a monofilamentous snare. I usually prefer to use the 10 or 15 millimeter sized snare for the piecemeal resection of such classical Paris 2A lesions. So the approach I would like to present to you in this case is shown here now. This is the end of the procedure, and as you can see up there in the 12 o'clock position, a visible vessel, not just a visible vessel, but also a vessel that is bleeding slightly. So I prefer to use a small clip to approach this vessel. And then after this, use prophylactic Next powder or a topical agent. In this situation, it was a Next powder. Next powder is an Hemospray, forms a mechanical barrier which improves coagulation below the mechanical barrier, so thereby preventing the possibility or lowering the possibility of delayed bleeding. Application is very easy, and as you can see here.
Very nice, thank you. Yeah, another complication is pancreatitis, no? Dr. Probst, can we prevent pancreatitis?
Maybe. I think we can reduce the risk a little bit by placing pancreatic stents, and this is a guideline recommendation also. And I selected one meta-analysis from 2 years ago, and you can see in a large number of patients the risk for pancreatitis after papillectomy was 11.4% for all patients. And when it was possible to place a stent, the risk was reduced to 5.9% compared to 18% when there was no stent. But I think we should not be too aggressive to place a stent. If it's simple and if it's easy to put a wire into the pancreatic duct, I think there's no question we should do. But if it's not possible very quickly, I think we should not be too aggressive to.
How is the success rate in our group? Do you know the precise number?
I know the number. It was about 50%.
50%.
And when we look at the patients who had pancreatitis afterwards, half of the patients, 50% had a stent and 50% had no stent. So I think there is a recommendation, but as I mentioned, we should not be too aggressive, in my opinion.
Okay, thank you. So yeah, now in the next couple of minutes, I would like to show you some new techniques. Now we were discussing regular classic piecemeal EMR or a block EMR for ampullary adenoma. The next technique is cold snap resection, as shown here. A lesion, I would say 2 centimeters, flat, Paris 1S, and no risk of malignancy. For sure, you should make a precise diagnosis. You can always use underwater inspection using different modes like NBI or BLI. And if no risk for malignancy, I think cold snap is also in the duodenum a very nice option. And the only question we can ask is injection necessary? I did it in this case. You see here, I injected the lesion with adrenaline and indigo carmine, and then I started the piecemeal EMR.
Yeah.
It's very fast, yeah, and looks safe. For sure, a block resection is too large for this lesion with cold snaring.
Yeah. Okay. So I think we got the whole lesion.
So 3 pieces.
3 pieces.
But I lost one. You see here,
so,
small remnant.
Yeah. Okay.
Yeah, and now at the end you see it's a very nice.
How the eye picks up vessels in the deep submucosa. 2 centimeters.
Yeah.
Resected now in 4 pieces. This is.
And again, we can discuss is closure necessary or not.
So this is our.
Yeah. So data on cold snaring, just one trial. Outcome of piecemeal in lesions larger than 1 centimeter, as in this study, a retrospective analysis which combined the lifting plus cold snare. Lesions were larger than 1 centimeter. You see 43 patients. The size was about 2.5 centimeters. Quite high rate of recurrences, 46%. And the median range for polyp eradication to endoscopic procedures because of the high recurrence rate. So we can conclude cold snare is for lesions larger than 1 centimeter, is safe in the duodenum, but has a higher risk of recurrence rates. Now another technique is underwater EMR. I show you another nice small lesion here in the duodenum.
Out to the tumor and inspect the lesion. It's a little bit depressed in the middle. The mucosal pattern seems to be a little bit disturbed. So this is an interesting case of a 62-year-old, better visible. For me, it's like a new white light, this TXI, and I like this mode.
So I think again inspection is very helpful at the very beginning, but then to continue now with underwater, the polyp is nicely floating, and sometimes it disappears at this almost shrinking. So you get larger pieces because you don't inject, don't enlarge the volume of the polyp. And we use here a 50 millimeter snare, and you see the small lesion, maybe 1 centimeter, and can be very precisely with underwater technique and NBI resected. So here you see how precise this is.
Who got it?
Yeah. Nice resection.
No. We catch the lesion.
Okay. So nice resection. We take it out and then small lesion, which is easy to close again with this.
Helps you to pick up bleeding spots. There's just a minor bleeding. I think we can close this defect easily with 2 or 3 clips, and then
So oops. Underwater technique, also just one trial showing underwater EMR for polyps smaller than 20 millimeters, multi-center prospective trial, 140 patients. And interestingly, you see here, non-ampullary adenomas less than 2 centimeters, a follow-up endoscopy at 2 and 12 months with taking biopsies. 10 were lost. The main take-home message is the low recurrence rate in these lesions, which were almost 2 centimeters, and safe. So compared to cold snap, we have a much lower recurrence rate. Maybe it's not comparable, but the technique shows similar to the technique in the colon, the recurrence rate goes down if you use underwater. And now something which is maybe not for everybody in his center. It's very special. It is a ESD procedure.
It is essential. So this lesion has some reddish areas, polypoid, and for sure EMR is a standard treatment in Europe. However, meanwhile, we also have some experience doing ESD, and therefore we try to inspect the papilla with a gastroscope if possible. And we have I think it's a 11 o'clock position. This is a patient,
Oops.
59-year-old.
Excuse me.
Reddish area is
now after staining with indigo carmine and TXI, a very nice delineation of the lesion. And this lesion had some abnormalities in the center and depressed areas. So I decided to go for a ESD procedure. Yeah. And then similar to ESD in the colon or in the gastric, in the stomach, after circumferential marking, then the circumferential incision. But you have to be very, very careful. I think this is one of the most tricky procedures I ever did, because the perforation risk is quite high. Initial data from Japan showed a perforation risk of 30%, and perforation in duodenum is not always easy to manage. So you should only do ESD in the duodenum if you have very much experience in the remaining GI tract. So in Augsburg, we do have now 2,000 ESD procedures over the years. The advantage I will show you on a slide. There is a nice lifting here, and with injection you definitely can work with this hook knife. Hook knife is safe. It's a bit slow but very precise. And then using the clip line technique as well in the duodenum, we could resect this lesion. Oops. The lesion completely. And then I close the defect, which has been shown in other videos as well. The advantage of ESD compared to cold polybectomy underwater EMR or EMR, you see the unblocked resection rate is much higher even for larger lesions. The rate of delayed adverse event, interestingly, is for the ESD group in large lesions less than in the non-ESD group, and the main benefit is for sure the recurrence rate, so the less recurrence, especially for the large lesions. Yeah, and then another technique which will be now presented by Dr. Probst again, full thickness resection. This is a case which was performed by Dr. Probst, and he will present you this case. Dr. Probst, please.
Yes, This was a residual or recurrent lesion. The patient had an EMR 2 years ago and repeated EMR and APC 1 year before. And then he had another recurrence with non-lifting. And we decided to perform full thickness resection. And the system is the same as it was developed for colorectal lesions. And there are many data for colorectal lesions now, but only few data for the duodenum. And the procedure is just the same. You grasp the lesion into the cap, then you apply the clip and close the snare, and then you remove this specimen. And afterwards, you check the resection site again. And you can see the clip has grasped the whole wall, and there is typical image of full thickness resection, and this is the specimen. And this was R0 resection of this multifocal adenoma with low-grade dysplasia. And after this procedure, I think the risk for another recurrence is nearly zero. So this is a new technique, and we have only few data today for duodenal full thickness resection. And you can show the next slide, please. We have one study here with 20 patients. This included adenoma in 13 cases, subepithelial lesions in 5 cases, and 1 early cancer. And it was possible to resect the lesion in 17 of these 20 patients, but the R0 resection was only 63%. And despite this low resection, R0 resection rate, there were only 2 recurrences. So I think this is preliminary data today, and there are no large studies. And I think we have to wait for larger studies to really show the value of this new method. And in my opinion, it's should be restricted to difficult lesions or recurrences, and the first line treatment should be the EMR, as we have shown before, or underwater or cold snare resection.
Okay, thank you, Dr. Probst. I think we will discuss at the end all these different techniques. I will now come to my end with 3 last cases showing all the complications, severe complications, as in this case. This was a 61-year-old man, definitely fit for surgery, but asking us, can you resect this lesion? And he was admitted. He had almost a stent in place from an external hospital. And as you see, it is a huge lesion, also involving the papilla. And I performed the resection. There was no risk for malignancy in this lesion. We could do piecemeal, as shown now in the other video images, very nicely. So we usually start at the upper end with small pieces and also grasping some regular tissue, and then continuing step by step, you see. And I can go forward. A very nice resection so far. No bleeding, no major bleeding in between. So it looked pretty good at this situation. There's the stent in situ. Then completing the resection, I removed the stent, and then I resected the papilla. You see here the resection of the papilla. And at the end, it was, I thought, well done. But you see, it's starting from smaller vessel, starting bleeding. It is always a question. Here is a spurting vessel. When to control? Usually we control the patients the next day. But in this situation, I decided I would like to have a control in the next 6 hours because we expect bleeding. We did some prophylaxis. Here again, a resection of some remaining tissue of adenoma. And at the end, we used again Hemospray. The pancreatic stent was inserted, and then Purastat, not Purastat, next powder was used. And I thought it might be enough, but we performed a control endoscopy, then was planned 6 hours later, but he had a severe bleeding after 2 hours. And in the next couple of days, he suffered several severe bleedings. And at the end, he developed a severe stricture. This is showing here. After a couple of days, this is now the situation after 2 weeks. Patient had a severe stricture. We had to place an OTSC clip. The stricture was not possible with the scope. So a really worse situation for the patient. There was no malignancy, and I think I can ask our expert, Marc Barthet, what to do in this situation. And another case, also interesting for complication, bleeding. Here again, underwater. I was thinking about whether I can remove this polyp underwater in one piece. It did not work, though I decided to inject, to resect it in one piece, which was possible, as you see here. I took the snare. I could get this lesion of about 2.5 centimeters in the snare. And now, after resection, you see the complication. You remove the resected piece. You can see in the was starting bleeding and coming back. You have a spurting vessel. Now there is a severe bleeding, and again with this new RDI technology, you can very precisely pick up this area and coagulate the lesion. And now you see here the complete coagulation at that time. And then the resected area is not so huge, so a complete closure with clips was possible. So bleeding, sometimes if it occurs immediately, can be managed. And now my last case, and this is a case which I would like to discuss with Marc Barthet. Marc, this is a 92-year-old lady. You see here, this was a papilla, and now above the papilla is a circumferential lesion. Length would say 2 to 3 centimeters. Here was an area which is a bit suspicious. I would say non-granular type in the colon, non-granular type lesion, but here all regular area, and then here we are in the bulb. So yeah, my last case, and I would like to show you this with different techniques for sure. What should I recommend this lady? She was admitted to our hospital asking, is she a candidate for resection? Here is this depressed area with, yeah. Is this a candidate for resection? Is this a candidate for surgery, or should we wait and watch? And that this is the end of my presentation. And yeah, Marc, let's start with your presentation and maybe a recommendation. What would you recommend? And George, I saw in the back there are dozens of questions coming in, and maybe we can answer a couple of questions right now, or we discuss it at the very end.
So you want my recommendation for this case now, or yes, just at the end?
Now? Immediately. Now. What would you do?
Immediately. So we have just to keep in mind this patient is an old woman because she's 92 years. Okay.
She looks like 70. She looks like 70. I tell you, never saw such a fit lady.
Okay, so I think we have to try to decrease any risk for this patient, because if you do such a resection, of course you have a risk of stenosis, like you shown in a very nice video, and bleeding, because it's a large lesion. So I think you have to just to resect the targeted areas where we followed. We have no more pit pattern visible. I think it's a 5A classification. And after you come back when you have the pathological results. And if you have no invasive carcinoma, you can do the complete resection. But keeping in mind, you have a risk of stenosis and a risk of bleeding. And if you have invasive carcinoma, I think you have no more things to do, and you have just to wait with the patient.
Yeah. Okay. Thank you.
I'm wondering whether a watch and wait strategy can be also valuable in such elderly patients.
Sure. This is what I discussed with the surgeon as well, to resect only the suspicious area, and if there's no invasive cancer, maybe we have a follow-up. Yeah, Dr. Probst, your opinion? But
I would prefer watch and wait.
Watch and wait. And now I can ask George and Marianna as well. Then we have the complete expert's opinion.
Well, I think the watch and wait is a good strategy for this type of patient, and but unfortunately we don't have enough data. I think this also reflects reactions that we had in the questions about watch and wait in this type of patients. So I think it's really discussing also with the team, but also with the patient, and see how they feel.
Yeah, I think that the 92-year-old lady who looked 70 before she comes into the endoscopy room may look
100 after.
May look 105 when she's afterwards. It's
after surgery.
The challenge, isn't it?
Okay.
Helmut, we've got some fantastic. We've got more than 500 attendees online.
Oh, great.
We've had some great questions coming through, and we can't answer all of them, but a couple that have been repeated questions.
Yeah.
One is the role of endoscopic ultrasound in the pre-resection assessment of both ampullary and non-ampullary lesions, and I just wonder if Marc might approach that. And the second, which certainly I know technically can be a real challenge, is the deployment of hemostatic clips, particularly through a duodenoscope. We're all pretty comfortable and familiar with deploying clips with a gastroscope, but if you're on the medial wall, then you can find that multiple clips drop off as you elevate the bridge on the duodenoscope. So I just wonder whether Marc might address the question of EUS, and then all of us might just sort of give some tips and experience of using clips.
Okay, George, thank you for this question. Just for EUS, for ampullary tumor, I think the only usefulness of EUS examination is to know about the extension to bile duct and to pancreatic duct. Because, the accuracy for differentiating a T1 or T2 tumor is very low with EUS at the level of the papilla, of the major papilla. So for me, EUS is, of course, needed, but only to have a clear delineation of the bile duct and the pancreatic duct to be sure you have no deep invasion inside the bile duct and the pancreatic duct. Like we saw in your video, Helmut, you show us videos with some tumor tissue inside the bile duct and the pancreatic duct. So this is the main, because for me, if you have a tumor inside the pancreatic duct or in the bile duct, for me, it's a contraindication for ampullary resection, even if we can discuss local treatment, but we are not sure about the result of this local treatment. And for duodenal adenomas, I think EUS is not required because it's very difficult to perform into the lumen of the duodenum first. And secondly, I think we have a very good approach with endoscopic assessment with the Paris classifications and with NBI or BLI, LCI, what you want, depending on the scope you use. You can be nearly sure about invasiveness of the tumor.
Yeah, very helpful. And with respect to ampullary lesions, pre-procedure MRCP, and if there is no dilatation of the pancreatic duct or the bile duct, do you think that EUS adds more in the exclusion of intraductal extension?
Yes, I think EUS is more precise than MRCP for invasion of bile duct and pancreatic duct, because sometimes you can have a non-dilated pancreatic duct or bile duct, and despite that, you can have invasion tumor invasion inside of the bile duct and the pancreatic duct. So I think the best choice for being sure about the bile duct and the pancreatic duct is EUS. It's more precise than MRCP.
Agree. I would do EUS, not MRCP. Depending on the size of the lesion, small lesion, 1 centimeter, I just would take it out. A diagnostic resection, no EUS is necessary in this case. If you have increase of the bilirubin, for sure, you can expect an obstruction. Then EUS is recommended definitely. And then we do always a papillotomy, because sometimes interductal adenoma protrudes and you can resect. And for sure, this is not curative, but in elderly patient, I think it's an option to avoid aggressive surgery.
But you know, we are looking to the ampullary tumor. We have also to consider sometimes you have intra-ampullary tumor, sometimes you have extra-ampullary tumor, sometimes you have both, and maybe the attitude for assessment before resection could be different if you have intra-ampullary tumor only or extra-ampullary tumor only or both.
Yeah.
You have just to adapt seeing the lesion endoscopically what you need for being sure about the resectability of the lesion.
Okay.
Helmut, do we have just 1 minute before we move on to the next section of
sure.
getting views on clips? You know, the deployment.
Honestly,
particularly via a duodenoscope. I don't know if
I tell you, honestly, I hate clipping because I had a perforation induced by clipping, though I tried to close as published in the Japanese data on Asian, they close everything. It's sometimes tricky with a duodenoscope. It's almost impossible, though you use a gastroscope. And in this case, I really had a disaster, and the patient needs operation, though it was not too close with Webster at the time. Therefore, maybe these topical agents like Hemospray, Purastat, Next powder, there are no randomized trials. We start now a randomized trial, hoping that this might have an effect. For sure, if it's a nice lesion and you can close without any risks, then it's possible. But for large defects, the risk of closure, this mechanical, induces probably perforation, and then the post surveillance is difficult. You have clipping, and you know there is a recurrence, and this to differentiate is sometimes more tricky than in the colon.
Yeah, and certainly just in terms of the mechanics of deploying a clip, I think the thing to avoid is if you're using a duodenoscope, is lifting the elevator with the clip only just out, because you invariably knock it off. Marc, do you have a
yes, we can give an advice, because when you are doing ampullary resection, sometimes you have bleeding at the top of the resection. Or sometimes at the down to the break of the papilla, and so you need to put your clip with a duodenoscope and not with a usual gastroscope, because you cannot see clearly with a usual gastroscope. But it's difficult to push out the clip. So I just share your advice. You have to retrieve the angulation of the distal part of the scope. So making down, not being close to the papilla, making down. You pull a little bit back the scope to straight the scope, and after you push blindly your clip. And when you have the feeling that the clip is outside, you can put a little bit up and elevator, and so you can see the clip. You ask to the nurse to open the clip, and after you can push your elevator towards the bleeding site of the papilla. This is a way to use clip. And I have to say, it's not advertising, but some clips only are usable with a duodenoscope. And for me, the best clip, I have no conflict of interest with a Cook, but is a Cook clip. This is the best one to use with a duodenoscope for me.
Yeah. that's my experience as well. I think it's the instinct clip. I might be wrong in that.
Yes, yes, exactly, the instinct clip. Yeah. And so don't forget, you try to straighten the scope by going down and back to the papilla, pulling a little bit back the scope to straighten the scope, and after you push blindly the clip until you feel by the contact with the mucosa that the clip is outside of the operating channel, and after you put a little bit up and a little bit elevator, and when you see the clip, you ask to the nurse to open the clip, and after you can put elevator and up position towards the site of the bleeding.
Great advice. Great advice. Helmut, we probably need to move forward, do we, to sure. Marc and Marianna?
We invited Marc because we know he had also great experience with treating these lesions and recently published also a paper on this resection of these duodenal adenomas. And I'm happy that Marc can give now his experience with his data. And yeah, Marc, please. Okay.
So thank you, Helmut, and congratulations for your so nice videos and all the example of different techniques to retrieve duodenal adenomas and ampullary tumors. So just no conflict of interest. So we have a lot of topic to speak about duodenal adenomas, and all are treated in the recent ESGE guidelines. And you see published just last year. And as it is expert and literature recommendations, I just want to speak about our own series published just after the ESGE guidelines about the result of endoscopic resection of duodenal adenomas. It's not speaking about ampullary tumors, like in the paper presented by Andreas, but it's only about duodenal adenomas. Okay, so just, okay. So we included 130 patients in 2 French centers located in Marseille, because a part of France is Marseille. And so I worked a lot with Marc Giovannini, and we put together our cases. And so we included 130 cases, and you see the mean size was 20 millimeter up to 5 centimeter. And you see 35% had high-grade dysplasia and 6% had intramucosal carcinoma. And looking to the result, the larger size you had, the highest Vienna classification you had, it was significant. So take care to large lesion, because in very large lesion you have a risk of carcinoma. But you have to know that we have clearly a discrepancy between the result of the biopsy before resection and the final histology in nearly half of the cases. So you have not to be confident with the biopsies, and you have only to have endoscopic evaluation for duodenal adenomas. And also take care to the association with colonic lesions, because you see in all these patients, 12 patients had colonic cancer after systematic colonoscopy, and about 60% had adenomatous polyps. So don't forget, if you treat duodenal adenomas, look to the colon of this patient, do systematic colonoscopy. This is a very important take-home message. So next slide. So we performed endoscopic resection in 129 patients. So and EMR was achieved in 96% of the cases. We did not perform any ESD, and all the cases of failure were due to no lifting. And I was interesting to see, Helmut, your lifting. You always start lifting at the periphery of the lesion, and for me, I'm always starting in the middle of the lesion to increase the unblock possibility for the resection. So unblock resection was nearly in half of the cases, but you see the lower size and the greater unblock resection rate. So more than 20 millimeter size, you have the risk of not doing unblock resection. Complete resection was achieved in 96% of the cases, and we look with a multivariate analysis for negative margins, and the best results for negative margins were obtained with small lesion size, of course, and unblocked resection. And the mean duration of the duodenal resection was 54 minutes. So I just show you, this is a papilla at 12, and this was a LST tumor of the duodenum. You see, sometimes it's very impressive, but you see, we always follow the pit pattern, the glandular pit pattern. And so we decided to endoscopically resect this lesion. And you see, I always start in the middle of the lesion to increase the capture. I use a 15 millimeter snare, okay, and you go close by close, okay, avoiding to let in place any adenomas bridge inside, okay. And I use a 25 millimeter gauge needle. And you see at the final step, about 3/4 of an hour resection time, we had a complete resection. And of course, with a so large resection, it's not possible to get closure, defect closure, okay? But you have to do, if you have any bleeding or any visible vessels, you have to clip, because this is the most efficient way to prevent bleeding, delayed bleeding. And just now about complication in our series, you see we had 16% of major complication, meaning bleeding and perforation. But we had mostly bleeding. You see the rate is 13% of the cases, and it is very close to the rate presented by Andreas Probst, which and he got 14% rate for delayed bleeding. And you see the bleeding is during the 3 days following the resection. So follow your patient, and I kept this patient for at least 4 days following the mucosal resection. Of course, if it is not a very small resection, less than 15 millimeter, and you see 80% of the lesion were measuring more than 20 millimeters. So take care, if it is more than 20 millimeter lesions, you have a risk of bleeding, about 15% rate. And so you have to keep the patient in your hospital because of the risk of bleeding during 3 days. And how to prevent delayed bleeding? We performed a multivariate analysis, and we showed that prophylactic clipping is the best way, endoscopic way, to prevent any delayed bleeding. So, of course, it's a problem, because after following the risk of recurrence, if you have any clipping, sometimes it's difficult because you have a sort of granulum, but it's the best way to prevent delayed bleeding. And also look to the presence of visible vessels. You have to have no more visible vessels at the end of the procedure. And what about perforation? The rate is very low with EMR, not with ESD, of course, about 4% of the cases. And there were 5 patients, 2 underwent surgery, and 3 underwent conservative or endoscopic treatment, meaning OTSC clip, or meaning in one case, duodenal stenting. And keep in mind that you can have also delayed perforation due to coagulation. So for doing endoscopic resection, I try to lose the less coagulation current I can. So for instance, I'm not using undercut Q current, but I'm using undercut I current, like for endoscopic sphincterotomy, to decrease the rate of delayed perforation. And one of the most dangerous device to use after endoscopic resection is APC. APC increase a lot the risk of delayed perforation. So avoid APC after endoscopic resection. So take care, because you can have also a delayed perforation. And what about the long-term efficiencies with a median follow-up 25 months? The factors associated with incomplete resection was a larger size of the lesions and depressed type. And the recurrence rate in our series is very close to the rate of 76% in the series of Andreas and Helmut. 71% of the patients had no recurrence at all, and nearly 3/4 of the recurrences were found during the first year of follow-up. So usually I take back the patient at 6 months, because if you take back the patient at 3 months, sometimes you have false positive or false negative. You have still inflammatory pattern, so you cannot have a good idea about the recurrence. And when you are sure about the endoscopic recurrence, you can do a successful endoscopic management in 72% of the cases by EMR mostly, and sometimes in combination with APC, but take care to APC or electrocoagulation. So this is my last slide about the real life. So in our cities, in 2 centers, 134 procedures. We followed clearly 105 procedures, and we had no recurrence in 71% of the cases, and recurrence in 30 patients out of the 105. 12 are still under endoscopic treatment, but about achieved treatment, and endoscopically managed were 72% of the cases, surgically managed were 27% of the cases. So finally, adding the treatment of recurrence and adding the primary results, positive results after endoscopic resection, the success of the endoscopic treatment was 83% of the cases. So thank you. This is my presentation about the real life in Marseille.
Thank you, Marc, for this outstanding presentation. I know that this is very, very interesting data and shows that even in centers, no, it's a challenge to treat these lesions. No?
Yeah, exactly.
Yeah.
Marc, Helmut, we had again some great questions coming through. A lot on that topic of delayed bleeding, and a couple of issues. Proton pump inhibitors, should we be giving them? Do they have a role? And also, we know that delayed bleeding can happen, a week, even 2 weeks after resection. Do you have a policy as to when you restart antiplatelet therapy or anticoagulant therapy?
Yes.
Well, yeah.
First to say that, of course, PPI are required in all the cases, and I try to avoid any vomiting from the patient, because some patients have vomiting just following the procedure, and they can tear the mucosal resection. So take care to that, and I provide to the patient some treatment to avoid vomiting during 1 day after the endoscopy, and the patient are fasting for 1 day after a large mucosal resection, not a small but a large one. And for taking again antiplatelet factor or anticoagulant, I wait for 10 days.
Okay. Okay.
10 days. I don't give back the antiplatelet treatment or anticoagulant treatment until 10 days, because sometimes you have a scar, and when you have the fall down of the scar, you have a risk of rebleeding if you are under anticoagulant treatment. So I wait for 10 days.
And Marc, do you also interrupt aspirin as well?
Yeah.
There are few endoscopic procedures.
This is the only case where I drop the aspirin treatment for duodenal resection, not for colonic, not for gastric, not for esophageal, but for duodenal, yes, because the risk of bleeding is so high with duodenal treatment that you have to really have any anticoagulant or antiplatelet treatment.
Yeah, if possible, we do it in the same way. This case where I showed the stricture, this patient had bleeding almost every day, and we continued a daily control endoscopy. At the end, we placed another biliary drainage and another pancreatic drainage because there are limited data that by avoiding that bile and pancreatic juices on this in this resected ulcer induces obviously also bleeding. So a very difficult situation, and we had to place Ovesco clips indeed, and this might also be now a problem now for the stricture. So very difficult sometimes, and yeah, discuss with the patient, discuss with your surgeon to have a plan. Yeah, but even in expert centers, sometimes you will have complications, and we saw it in our series as well. Yeah.
Can I just on that point, you know, the role of surgeons, etc. You know, Marc and others, the role of the multidisciplinary team. These are challenging patients. There is debate as to what the best initial approach might be. Should these patients all be discussed within a multidisciplinary format? Is that something you do? Is that something you would recommend?
Yeah, we have always for this patient a multidisciplinary discussion to assess clearly the balance benefit risk. Like for the patient of Helmut with 92 years, but looking like 70 years. So if you have no discussion, it is out of the guidelines. So you have to have a clear discussion about the benefit and the risk for this patient to do any endoscopic resection, and asking to all the experts here, everyone has a different advice for managing this patient. So we always have a multidisciplinary discussion, of course, not for small adenomas, 10 or 15 millimeters, and patients without any risk, any morbidity. But in other cases, we are always discussing.
Yeah, I agree with
you. Also, what we do, we are not doing endoscopic resection before the weekend or before going in holidays, because if you have any complications, it's difficult for your colleagues who has to treat your complications. So maybe
this is a fair approach.
This is
you should think about.
Very good advice.
Yeah.
Agree.
We could talk about this topic all evening, but I think that I think we probably need to move on to Marianna's presentation, the guidelines, and hopefully we'll have a few minutes at the end to just discuss one or two more points.
Thanks.
So thanks for also for including me in this fantastic first edition of a live case webinar. So I had the privilege of being part of the guidelines with this fantastic team and experts, and I really learned a lot with these guidelines. So we split it. We did appullary tumors and non-appullary duodenal tumors. And so I'll start with the major recommendations from both parts. So for the appullary lesions, we talk about the latest TNM classification. Of course, this is for cancerous lesions. But what is interesting is to see the anatomy of these lesions. And when we talk about ampulectomy, what do we really talk about? And so when we take out a lesion, a benign lesion, we usually have lesions that are really limited to the duodenal mucosa and the sphincter of Oddi. And what Marc pointed out about it's very difficult to discern between T1 and T2, and further between T1A, which is when it's limited to the ampulla of sphincter of Oddi, and when it invades the duodenal mucosa. This is impossible to do with the current diagnostic tools that we have, and everything that's, of course, T1, usually traditionally in a patient that's fit for surgery and you want a curative approach, you probably go for a surgical resection, a Whipple. So this is important to know because of that anatomy is important to know before deciding what you're going to do. So what about diagnosis for the ampullary lesions? So when you have a linear and when you have a forward view scope, you know that you might not see the papilla very well. It's in the quality indicators of the upper GI endoscopy to see the papilla, but we know that's not always easy, and a cap can facilitate the view of the papilla. But if you're really planning to do, if you're really suspecting there is an ampullary tumor, you have to evaluate, assess the lesion for resection. You will use a side viewing endoscope, and a high resolution virtual chromodoscopy can help in the endoscopic diagnostics and staging, but this is still, we need some more data on that. Still, we require biopsies, but we know that, as Marc showed also in the Marseille experience, that accuracy is low, and you can have over-evaluation and under-evaluation, but we still recommend against doing a diagnostic therapeutic papillectomy when adenoma has not been proven. And we also recommend histological confirmation in case of a low-grade dysplasia before initiating any treatments. In cases where you have you're not sure that the lesion has to be resected, we can follow up, and also with US and the side view endoscope and further sampling. We talked about MRI, we talked about US, both can be used for staging. But mostly when as Marc pointed out, is really to evaluate the extension in the bile duct and the pancreatic duct. We can use MRI, but it has to be a good quality MRI with a very good interpretation by a radiologist that have experience in this technique. And both techniques also can help you define the anatomy of the pancreatic duct. Of course, you have pancreas division and you have an ampullary lesion of the major papilla. You will not try to put in a pancreatic stent if you don't have, if you just have a very small ventral duct. So it's important to know that beforehand as well. So we recommend endoscopic papillectomy in patients with ampullary adenoma without intraductal extension. This is also the study that's been shown, the systematic review, where we show that we have good rates of complete resection and curative resection. We'll talk about recurrences, but it's still an issue. And of course, on adverse events, 1/4 of patients will have adverse events, and the most frequent ones are bleeding and acute pancreatitis. And we recommend in block resection for lesions up to 20 to 30 millimeters to achieve our zero resection. In cases where endoscopic ampulectomy is technically not achievable, if you have like a big diverticulum and other reasons, we can go for a surgical ampulectomy. But if we have a neoplastic lesion, in this case, we have to go for a Whipple. This is also a good series from the Sydney team. So we see that we can have both. We can have an ampullary lesion and we can have a large extension in the duodenum, so lateral spreading tumor in the duodenal. So we can also resect both endoscopically, but we know that these procedures will take longer and will have maybe more advanced pathology and also more bleeding compared with a simple ampullary adenoma. What about intraductal growth? We've also talked about that. In cases where this is limited, less than 20 millimeters in expert centers, we can use some complementary techniques, radiofrequency ablation or thermal ablation by cystotome. There are some studies, but this really has to be defined according to the patient. Technical considerations for ampulectomy. So no submucosal ejection for endoscopic papillectomy only if there is a lateral extension. And Helmut referred to this randomized controlled trial where finally the injection really didn't offer anything, and finally the group without injection had a better complete resection rate. we try not to do any sphincterotomy before doing the resection, because we might change the anatomical landmarks, and this is very important if you're going to refer your patient later. But we can do a sphincterotomy after resection if there's a delayed emptying or intraductal growth requiring a complementary treatment or a stenting. And we also talked about the current for the ampulectomy. So what about the bleeding and acute pancreatitis, the two major adverse events following ampulectomy? So there's a lot of techniques for hemostasis that we can use, and this should be used for per procedural or post-procedural bleeding. And of course, in massive bleeding, you can still call your friends from the interventional radiology department. For acute pancreatitis, rectal NSAIDs, it's a recommendation, but it can help, extrapolated from the ERCP literature. And stenting has been shown that it can protect if we can find easily the pancreatic duct, and of course it's not pancreas division. And finally, recommendation for hydration in case we have contraindications for the NSAIDs. Follow-up is important. We see the recurrence rate, and so it's within the first month, but after 6 and 12 months, and therefore yearly, at least for 5 years. And this is probably where even expert centers lack the good follow-up, because these patients come for the resection in an expert center and then they will go back to be followed. So it's very important to give instructions about the follow-up. And fortunately, we can still offer endoscopic treatment in case of recurrence. So we'll go to the duodenal tumors. So these should be considered for endoscopic resection because they progress to invasive carcinoma. And we talked about the performance of colonoscopy. There is a higher probability of these patients to have also colon adenomas, and this is not only for genetic in a genetic setting, but also for sporadic duodenal adenomas. So you have to do the colonoscopy in these patients. In this case, relevant biopsies are very limited, as Marc studies showed out, and we really have to use the endoscopic evaluation to determine invasion. Again, we have to also determine if the lesion, the duodenal lesion, is related to the papillary, to the major or the minor papilla, and for that the cap-assisted method or using a side viewing endoscope are useful. And probably in this case, magnifying chromoendoscopy will help in improving the staging of these lesions. So treatments, we showed all these techniques in this great videos from the Helmut team, and cold snare polypectomy can be used for small, less than 6 millimeters non-malignant duodenal adenomas. EMR is the main tool as first-line endoscopic resection for larger adenomas, and ESD is only in expert hands. As we saw, we still have quite a lot of morbidity related to this technique, but probably in expert hands, better complete resection rates and less recurrence in the long term. And Helmut also referred to the study from the expert Japanese centers where for larger lesions, ESD seemed to have less adverse events than EMR. But of course, this does not reflect Western experience. What else can we use? Also, full thickness resection can be an alternative in cases where you have a non-lifting adenoma up to 25 millimeters in size with no signs of deep colon invasion. And we talked about APC. Not only it can add to the adverse events, but it also doesn't seem to have any efficient as a tumor destructive technique in the long term, with still a large percentage of recurrence. Prevention of adverse events. So we have bleeding and perforation. Again, here we see that ESD techniques have a higher risk. And we talked about all the preventive measures that we can take to reduce bleeding and perforation. And finally, for the follow-up, again, recurrence rates up to 15%. This will depend on the size, on the histology, on the technique. As we said, ESD, maybe there is a less high recurrence rates, but surveillance is important, starting 3 months from the index treatment. And again, we can retreat these patients by endoscopy if recurrence is detected. So to wrap up, so ampullary lesions, there's still a role of biopsy before resection. We complete the workup with MRI or US according to the local expertise. And block resections for lesions up to 20 to 30 millimeters with no intraductal extension. And we do not inject supracosal saline except for these ampullary lesions that are combined with lateral spreading duodenal lesions. On the other hand, in duodenal adenomas, there's a limited role of biopsies. We really use endoscopic evaluation. Cold snare can be used for smaller lesions. EMR, the major resection technique in ESD and FTR for expert hands. We have to be able to acknowledge and to manage the adverse events, and in both cases, follow-up is necessary. So thank you for your attention.
Thank you, Marianna, for giving us now an overview about our guidelines. I think it's always important to know these guidelines and the recommendation of experts. And guidelines sometimes guide you. Yeah, sometimes you cannot do really the strict recommendations, but for sure, I think it's a lot of experience in these guidelines, and ESGE has a lot of very, very important guidelines on different topics. So I think ESGE is very active regarding technical procedures. Okay, George, there are still dozens of questions I answered in the meantime.
You did some of your homework.
In the chat. Yeah, couple of questions. So stricture prevention was one question. It's difficult in the duodenum. In the esophagus, we use steroids. In the duodenum, I think, yeah, delayed perforation is risky. Yeah, we can try in a low dose. Yeah, we don't have experience, no data to my knowledge. No.
There's an interesting question about if we can survey small lesions of the ampulla of under 1 centimeter and I suppose low-grade dysplasia. I would say that we still have time to survey these lesions, especially in patients that are unfit for surgery, for endoscopic resection in elderly patients.
Yeah, I would say it depends on the age of the patient. No, the risk for small lesions is not as high.
Yeah.
So usually, if I have a young lady, I would resect. But for a 92-year-old lady who is looking like 70 years old, we can also watch and wait, Marc.
And also depending on the genetic pattern, because we know that the risk for familial polyposis, adenomatosis polyposis, is very low if you have a ampullary tumor lower than 1 centimeter.
Yeah.
So in such case, you are not obliged to systematically retrieve the ampullary tumor. You can follow it.
There's been some questions actually about polyposis syndromes and sporadic adenomas, and whether there should be a different endoscopic approach to resection, whether the patient falls within a polyposis syndrome, FAP, for example, versus sporadic adenomas. Marc, do you have a view, or would you just assess and resect according to the appearance, independent of whether this is as part of a polyposis syndrome?
I think you have a very recent paper in GI endoscopy showing that if you have a lesion, ampullary tumor less than 1 centimeter in case of familial adenomatosis polyposis, you are not obliged to retrieve the ampullary tumor, and you can follow. Why? Because I think this is the most risky situation for doing ampullary resection, because the pancreas is completely normal. Usually it's young people, and you have high risk of pancreatitis and high risk of complication. And I had this case in 2 cases in patients going into intensive care unit despite NSAID, despite prophylactic stenting. So I wait as much as I can and I follow the patient. And this is now a clear conclusion. When you are following such patients, you can follow the patient if the lesion is less than 1 centimeter.
Yeah, very interesting.
Very recent publication in GI Endoscopy about it.
There are some questions on OTSC clips. Maybe we ask Dr. Probst, as he has a couple of experience using for thickness resection. It's difficult to remove, or how can we exclude a recurrence? If we had a case yesterday in our clinic, no? The patient came back. We had this over the scope clip used because of bleeding, and then he comes back for a follow-up. Should we remove this clip? I think Dr. Ebigbo, you did this case, and the other was a full thickness resection. Always necessary to remove the clip for the follow-up?
If it's R0 resection and if there is no evidence of recurrence, I would not remove it. If it's not R0 and if it's suspicious signs for residual adenoma, I would remove it. And I have one comment regarding OTS for delayed bleeding. We should not forget embolization. If there is severe bleeding, I think we should. In our series, we had 25 of the severe bleedings underwent embolization. So we should not forget this, as mentioned in the guideline.
Okay. Wow. I think we cannot answer all the questions, George.
No, I think we've been a bit of a victim of our own success. You know, we've had fantastic engagement from attendees, which is great, and some great questions have come in, and we haven't been able to answer them all. You know, it may be that ESGE can look at some of the points that are raised, including, for example, a question as to whether the staging slides, Marianna, that you showed, whether that can be made available. And certainly I believe that these webinars will be available on the for further review on the ESGE site.
Yeah, sure.
So, you know, if there are bits and pieces that people haven't picked up or want to go over again, you know, I'm sure there'll be the opportunity to do that. But as I say, we could keep on talking till midnight, but I think possible.
I think we should come to an end. Yeah, I think it was a fantastic starter for this kind of webinars, and I'm happy to announce our next webinars. So there will be a couple of meetings for sure. The highlight of this year, and I hope all of those who were today participating, please note this date. Our ESGE days in April. I think we are all now in a situation where we can go for an on-site meeting. The Corona disaster hopefully goes down. The tsunami is slowing down. So we are really optimistic that we can meet in Prague. In the Congress Center, more than 3,000 participants are allowed. And you see on our webpage, there are a couple of interesting topics in the program. And Marianna is doing a fantastic job, has a great scientific program. We have a live endoscopy from Prague and from Rome with really great experts. So I think it's worth to visit Prague. It's a beautiful city. It will be nice weather, I promise, and it will be hopefully a wonderful meeting. And for those who cannot wait until, please, join us as a member. There are so many options that you have and benefits as an ESGE member. So it's not very expensive. So I think you have different options either via the dual membership in US societies and the national societies offers a younger generation for the fellows. It's also very attractive and you have so many benefits. So looking forward to become members and increase the numbers. Now, next week, we have the next webinar, the long and winding road, tips and tricks for successful colonoscopy. Again, a great panelist, Michael Kaminski from Warsaw, Manmet Mataharu, and David Tate, great experts in lower GI. So join next week. And in March, we will have the second event of this video live endoscopy meeting. And it will come from UCL, from George Webster's department. I'm happy that then at this stage, at this meeting, George, you will present cases from your unit and we will invite experts and discuss with our participants. And now I'm really, it's a pleasure to thank all of those who are involved in this many webinars, our governing board, and also thanking not only to the moderators, to the speakers today, to our experts, but also to David and Gabi, who work in the back stage, doing a fantastic job that you can now, meanwhile, every week on Wednesday, join this wonderful webinar. So yeah, enjoy now your evening. It was a pleasure to discuss with you. It was great. And thank you, Marianna. Thank you, Marc. Thank you to my co-workers, Andreas Probst and Alanna Ebigbo. And George, it was a pleasure with you to start this new webinar series and hope to see you soon. And yeah, I'm really happy that we had almost 500 participants today.
Great.
So cheers, bye-bye, good evening.
Bye-bye, cheers.
See you in Prague.
Yes, see you in Prague.
See you in Prague.
We'll share a beer.